If you've ever watched your child blink repeatedly, clear their throat, flap their hands, or make a sound they can't seem to stop, and you found yourself wondering, is this a tic? Is this stimming? Does my child have Tourette's? Then this video is for you. I am Dr. Takon, a consultant neurodevelopmental pediatrician. And in clinic, I hear versions of these three questions almost every single week. My son keeps clearing his throat. Is that a tic, or is he just doing it for attention? My daughter flaps her hands when she's excited. Should I be worried? And the big one, does this mean my child has Tourette's? By the end of this video, you'll be able to tell these three things apart, understand why they get confused. So why do stimming, tics, and Tourette's get mixed up so often? Clarity. Partly because they look alike on the surface. Both stimming and tics are repetitive. They can both be movements or sounds, and they both tend to increase when a child is tired, anxious, or overstimulated. But here's something that surprises a lot of parents. These things don't just look similar, they can genuinely overlap in the same child. Tics are actually more common in autistic children than in the general population, and a large proportion of children with Tourette's also have ADHD, so it's not always one or the other. Real children are complicated, and that's completely okay. What matters isn't getting a perfect label on day one. It's understanding what your child is experiencing so you can support them well. Let's start with some clear definitions, because these three words get used almost interchangeably in playgrounds, staff rooms, and even clinic waiting rooms, and they're not the same thing. First, stimming, short for self-stimulatory behavior. Stimming is something a child does to seek comfort, to focus, or to get sensory input. Think hand flapping when excited, rocking back and forth, humming, or repeating a favorite phrase. It tends to feel good. It serves a purpose. Second, tic disorders. A tic is a sudden, repetitive, involuntary movement or sound. Involuntary means the child isn't choosing to do it. Common examples include blinking, shoulder shrugging, throat clearing, and sniffing. And third, Tourette syndrome. Tourette's is a specific diagnosis that means a child has multiple motor tics, that's movement tics, plus at least one vocal tic, that's a sound tic, and those have been present for more than 1 year. One more thing about Tourette's, it doesn't usually look like what you've seen on television. The Hollywood version, where someone shouts words involuntarily, is actually rare. Most children with Tourette's have a very different experience. Now I want to tell you about the single most useful clinical clue for telling tics, apart from stimming. It's called the premonitory urge, and once you understand it, everything starts to make more sense. A premonitory urge is a feeling that builds up just before a tic happens. Think of it like an itch that keeps getting more and more intense until you finally scratch it. The tic is the scratch, and for a moment, the feeling goes away. Most children with tics can describe this feeling if you ask them. It might feel like pressure or tension or just a sense that something has to happen. Stimming doesn't usually work this way. Stimming is more like reaching for something comforting, a favorite jumper, a familiar song. It tends to feel pleasant, not like pressure that needs releasing. So if your child says, I just have to do it, or it feels wrong if I don't, that's worth noting. That's the premonitory urge talking, and it's an important thing to tell the clinician when you go for an assessment. Here's another important difference. What happens when a child tries to stop? Stimming can often be paused or redirected, especially when a child is completely absorbed in something else. It's flexible. Tics can be suppressed too. Children can often hold them in for a while, during a lesson or a social situation where they feel self-conscious, but it takes real effort, and there's usually a rebound afterwards. Once they're home, once they relax, the tics come out in a rush. Parents often notice this after school. The child seems fine all day, then the tics are much more frequent once they're through the front door. There's one more difference that's really important: pattern over time. Stimming tends to be consistent, the same flap, the same rock. Tics, especially in Tourette's, change. They move around the body. They wax and wane over weeks and months. A child might have eye blinking for a few weeks, then it stops, and shoulder shrugging starts. This is completely typical of tic disorders. It's not a sign things are getting worse, it's just how tics behave. Here's a practical question I want you to sit with. Ask yourself, what is this doing for my child? If the movement or sound seems to calm them down, or helps them focus, or comes out when they're excited and happy, that's pointing towards stimming. It's purposeful, it's working for them. If it seems to come out of nowhere with no obvious trigger, no obvious purpose, if it even happens when they're asleep, that's pointing more towards a tic. Now, and this is really important, this is a first lens, it's not a diagnosis. A full assessment looks at the whole picture, the movements themselves, what triggers them, the timing, and what else is traveling alongside. But asking, what is this doing for my child, is a good place to start. It shifts you from what's wrong to what does my child need? And that's always the better question. You don't need to memorize the clinical categories, but it can help to know what a clinician is actually checking for, so you're not going in blind. There are three main categories. First, provisional tic disorder. This is when tics have been present for less than 1 year. It's the starting point for many children. Second, persistent or chronic tic disorder. This is when motor tics or vocal tics have been present for more than 1 year. And third, Tourette syndrome. This means multiple motor tics plus at least one vocal tic, present for more than 1 year, not fully explained by another condition. That's it, 3 categories, and the boundaries between them can shift as your child grows. What matters isn't where they sit today, it's that they're being seen, understood, and supported. There are 5 things I want every parent watching this to carry with them. 1. You don't need the perfect label before you ask for help. If the movements are new, frequent, distressing, or affecting your child at school or with friends, that is reason enough to ask for an assessment. Don't wait for certainty. 2. Please don't ask your child to just stop. Suppressing tics is exhausting. It's like asking someone to hold in a sneeze for hours, and removing stimming without offering an alternative leaves children more dysregulated, not less. 3. Not every tic needs treatment. Many are mild, they come and go. They just need patience and understanding. A diagnosis isn't automatically a problem to fix. 4. Watch what's traveling alongside. ADHD and OCD are common companions to tic disorders, and they often affect daily life far more than the tics themselves. A good assessment looks at the whole child. 5. Acceptance and management are not opposites. You can support a child with distressing tics while never treating harmless stimming as something to fix. The goal is comfort and function, not looking typical. So what happens if tics are causing real distress or getting in the way of daily life? The recommended first-line treatment is something called CBIT, Comprehensive Behavioral Intervention for Tics. I know that's a mouthful, but the idea behind it is simple. CBIT works by helping a child to notice that premonitory urge, that building feeling, early. And instead of suppressing the tic, they use what's called a competing response, a different movement or action that's incompatible with the tic. It's not about willpower, it's about building awareness. And it's evidence-based, meaning we have good research showing it works. CBIT is non-medication. It's done with a trained therapist, and for many children it makes a real difference. Medication is also an option. And that conversation happens with a specialist when CBIT alone isn't enough. The key message here is there is support available. You don't have to just watch and wait if your child is struggling. Before we finish, here's a quick recap of the key differences, all in one place. Stimming tends to feel purposeful and soothing. Tics and Tourette's are involuntary and urge driven. The premonitory urge, that building feeling, is rarely present with stimming, but usually present with tics. Stimming follows a consistent pattern. Tics change over time, waxing and waning. Stimming can often be redirected. Tics can be suppressed, but they tend to rebound. And when it comes to what travels alongside, stimming is most commonly seen with autism and ADHD. Tics and Tourette's often travel with ADHD and OCD. No single feature tells the whole story, but together they paint a picture. Getting the label exactly right matters far less than making sure your child feels understood and supported. If anything in this video sounded familiar, if you found yourself nodding or thinking, "That's my child," that's your cue to ask for an assessment, not to panic, just to get clarity. Speak to your GP or pediatrician. Ask for a referral to a consultant neurodevelopmental pediatrician for a full assessment. If tics are part of the picture, CBIT therapist directories are available through national tic disorder organizations. And if you want to keep learning, you can find more episodes of Early Intervention Matters wherever you listen to podcasts. The goal is always comfort and function, not looking typical. I'm Dr. Inyang Takon. Thank you for watching.